As you all know, the CheckMate 9ER trial is a phase 3 trial that compared nivolumab plus cabozantinib versus sunitinib in frontline treatment for patients with advanced or metastatic renal cell carcinoma. The data were presented at ESMO 2020, and the trial met the three primary efficacy endpoints: an increase in progression-free survival, an increase in overall survival, and in the response rate, with an improvement in the quality of life and a manageable adverse event profile. So important data regarding this trial have been presented into abstract at ASCO GU with extended follow-up of 16 months. The first abstract gives data about efficacy endpoints with extended follow-up of 16 months in the overall population, and analyzes also the efficacy in the subgroup of patients with sarcomatoid features. So with this extended follow-up, efficacy data are confirmed, and they confirm the superior efficacy of nivo-cabo over sunitinib. The risk of disease progression or death was decreased by 48%, and the median progression-free survival remained double with the combination versus sunitinib. And the risk of death was decreased in 34%, and the overall response rate remained approximately double in the combination arm versus sunitinib, with an increase over the time of patients achieving a complete response up to 9.3%. Regarding patients with sarcomatoid features, we know that conventional therapies have been ineffective, and the overall 5-year survival remained very, very poor. Genomic analysis have shown that sarcomatoid renal cell carcinoma have higher PD-1 and PD-L1 expression than other subtypes of renal cell carcinoma. We had some data from other IO-based combinations with nivo, ipi, axi-pembro, and axi-avelumab showing improved responses and outcomes. So the present study analyzes the efficacy of nivolumab cabozantinib in the sarcomatoid subgroup of patients. The efficacy data were consistent with those in the ITT population in terms of progression-free survival, overall response rate, and duration of response. So therefore, this is a great opportunity for this subgroup of patients. The second abstract gives updated information regarding quality of life in this patient. Nivolumab plus cabozantinib showed better quality of life over sunitinib, with statistically significant differences between the treatment arms favoring nivolumab and cabozantinib. Furthermore, compared with sunitinib, patients in the combination arm experience a delay in deterioration, and these results confirm that superior clinical efficacy of the combination of nivolumab plus cabozantinib over sunitinib is accompanied by an additional benefit of better quality of life, and also support the acceptable tolerability profile in the nivo-cabo combination for the patients with advanced renal cell carcinoma. One of the biggest handicaps we have when treating renal cell carcinoma is the lack of reliable biomarkers. We have very interesting data regarding genetic profiles of patients showing a more angiogenic profile or more immunogenic profile that I'm pretty sure that in the future will help us in decision making, but today none of them are validated. If we make a comparison across the clinical trials, that is something that we shouldn't do, but we do all the time, and we cannot see big differences in terms of progression-free survival and overall survival. It's true that the combinations containing a VEGF have a higher response rate. But from my point of view, the most important difference is the progression disease rate. The progression disease rate is lower in the VEGF containing regimens. And this is very important, especially in patients with rapidly progressive disease. In this kind of patients, we have what we call sometimes just one shot. So you have to be right in the first treatment you use. And this would give us a better opportunity if we use combinations with the lowest progression disease rate. But on the other hand, the duration of response is longer in the CheckMate 214 in the IO-IO combination. So while the duration of response in the VEGF-based combination is around 20-26 months, this duration of response has not been reached in the CheckMate 214, despite being the study with the longest follow-up. And this is something that we can see when that can be seen reflected in the shape of the overall survival curves. But although I think this difference is really important, unfortunately, today we don't have enough data to select and to identify which of those patients will be the one that achieves these very, very durable responses. So we need to work on biomarkers. We are working a lot on biomarkers that help us to choose the right treatment for the right patient.